We're sort of on cruise control now for the final section of this robotics course. This is our opportunity to have companies in a non-CME format be able to present new technology that is usually not really allowed in normal CME courses because of the rules of CME. So this is sort of our opportunity to get smaller companies, companies with new technology that's not really even FDA approved yet, to allow them to have an early demonstration to our virtual viewers as well as our in-person. So the first technology we're going to have is VUZE, which is a 3D guidance without any navigational hardware. They're out of Israel, and I believe we have a video that we're going to play, and then we'll follow that with a demonstration by Aesculap, and then Stryker, Brainlab, and then finally with J&J Medtech Velys' new spine robot.
Hello, good afternoon, and thank you for attending our session. I'm David Tolkowski, CEO of VUZE Medical, and today we shall be demonstrating our software-based guidance and verification, currently FDA cleared for spine surgery. The technology is applicable to any skeletal portion. And as you will see throughout the demonstration, we're doing that without any navigational hardware. All we need in the OR is a 2D C-arm and an off-the-shelf PC running the VUZE software. With me are three surgeons, Dr. Paul Slosar, Dr. Geron Schiffer, and Dr. Shai Menachem. Dr. Slosar?
Thank you, David. So for those of you who don't know me, my name is Paul Slosar. I was the Chief Medical Officer for Titan Spine. But more importantly, I've been a practicing spine surgeon for 28 years. Had a pretty traditional degenerative spine practice like many of you. T10 to the pelvis, some complex deformity, but a lot of standard L4 to the sacrum and some ASC work. I'm here because I met David a couple years ago, and we reconnected about 6 months ago as the VUZE technology platform matured. And I watched Dr. Geron Schiffer, who's one of the surgeons here, on Orthopedics This Week masterclass, and I was blown away. I actually couldn't believe what they are doing with just a C-arm. So I actually flew to Cologne, Germany. I spent 7 hours in their cadaver lab. I did 14 surgical levels. I tried every trick I knew to break it, to mess it up, to mix it up. And the technology was bulletproof. I think this is an extraordinarily simple, yet really accurate complement to the existing navigation platforms. So for those of you looking for assurance to take C-arm technology and image navigation, or if you will, image guidance down the pedicle, I'll give you a little clue. Once you start seeing the axial view that's generated by this C-arm superimposed on a CT scan, you'll become addicted to it as a surgeon. It's an amazing transformation to take this, and I see a great opportunity for this for ASC surgeries and other markets where bigger equipment, more complex navigation platforms may be not necessary.
Thank you, Dr. Slosar. What VUZE does, if we start by summarizing it so that it'll be better understood once you see the demonstration, whenever a new X-ray is acquired, VUZE, by means of image processing only, detects the surgical tools in the X-rays, and the dotted yellow lines you see there are the detection. What it does next is that it registers that 2D X-ray with a prior 3D scan of the same vertebra. And that 3D scan can be any standard pre-op CT, we don't mind the prone supine issue, or a 3D scan in the OR, be it with an OC 3D or a Siemens Sire spin or a Medtronic O-arm, or Zeem RFD 3D, any of those we're compatible with. Once it does those two things, it takes the surgical tools from the X-rays that it has detected in the X-rays and places them virtually within the 3D data of the same vertebra or vertebrae from that prior scan that I mentioned, and shows the cross-sectional views, the traditional navigation views that today require a lot of hardware in order to generate, shows those axial, sagittal, along the longitudinal axis of the tools. And as you will see throughout demonstration, this whole process takes about 2.5 seconds. VUZE requires only AP X-rays because one of the early requests from surgeons was to avoid laterals, and even those APs do not need to be Ferguson views, parallel end plates, etc. Just any generally AP would do. So while doing that, VUZE, unlike traditional hardware-based navigation, affects no cumbersome preparation. The only preparation is connecting the video cable to the C-arm. No workflow disruptions, no cameras, no markers, no references, no tool add-ons, only a 2D C-arm and a PC. We start by very simple planning, can be performed on a laptop or on the VUZE PC in the OR, and then we start the procedure. We start the procedure by making an incision that is as small as possible. For that, we need one X-ray image, typically acquired at 0,0, and we see the scalpel relative to the planned incision site. That's the dotted cyan circle, so that the scalpel can be positioned such that the incision is very, very small, which is, of course, desirable for many reasons. Once the incision has been made, a Jamshidi is inserted and we acquire a first X-ray from a generally AP view. And what you see here is the prior planning from the current angles of the C-arm projected on the 2D X-ray so that you can see how your tool is relative to the planned insertion trajectory and to the planned vertebral entry point. If that looks reasonably close to planning, a second X-ray is acquired, and we only need that X-ray to be at least 10 degrees apart, still generally AP. And once we have those two X-rays, we instantly generate the cross-sectional views that all surgeons desire, the axial and sagittal cross-sections. In those cross-sections, you see the tool. The tool is a solid yellow line, and the cyan notches are how far you still have to go. Each notch is 5 millimeters. If you're happy with the trajectory, you insert the tool further, tool exchange, etc., and then only one X-ray is required to ascertain the depth. In essence, is the surgical workflow, and now I shall hand it over to Dr. Schiffer and Dr. Menachem.
So now we will do the tandem mode on L5. Maybe most of you would agree that it is not so an easy level, because you have quite to come far from the lateral. Sometimes it's not so easy to find the correct entrance point. At this, we would just place both our scalpels, as this is a tool which allows us to work with two surgeons on the same vertebra. And again, as you've seen before, we first start with the incision site. So we acquire an X-ray, AP 00. And you now see that mine on the right side, I have to go far from lateral and proximal. I move my scalpel. Shay also does that. Okay, new X-ray. Okay, so you're happy?
Okay. Yeah, I'm happy with my position.
Okay, so I do it a little bit more lateral and proximate. Of course, this procedure affords a little bit of communication between the surgeons. So you're happy? Okay, so please X-ray. Okay, so now I'm quite happy with my position. Jay, probably you want to correct it a little bit?
Yeah, I'll change my position a bit. Okay.
Okay. So we are both near the magenta spot. So we will acquire a second IMRI. We will accept that. And LAO2 cranial 25. X-ray. So again, we have these two images and can calculate the cross sections. So now we have the visualization of the cross sections for both surgeons. So on the right side, that are mine visualizations, and on the left side are Shay's. I think we can both be happy with that. Okay.
Yeah, pretty good.
Okay. So we advance the needle. Okay, once again, so the image can be acquired in this position. Please X-ray. And then we move to another position. In fact, the system calculates the optimal angles so that both Jamshidi needles can be seen by the system well. But of course, you see that we need only half of the radiation compared to the single site technique. Okay, so we exchange to K-wires. Okay, so again, X-ray please. And the second image. So that's the final position of our K-wires. I think you get an impression how fast and with how less radiation it is possible to place two K-wires.
That's the
Okay,
spin.
we do a spin. And I think you would agree that we have a perfect match between the VUZE visualization and the reality reflected by the C-arm spin.
So can we provide a few additional details?
Yes, you can.
Okay, just to clarify, VUZE is FDA cleared. To date, we had 59 clinical cases, all in Israel at a large 1,100 bed medical center. 8 surgeons have used the system clinically. Another 30 have used it in cadaveric surgery, where we also did SI fusion, S2AI fusion, single position lateral lumbar interbody fusion, all of those. And we are now looking for 1 or 2 pre-commercial US sites to further expand our clinical data. And I will enable Dr. Slosar to provide any additional information and answer questions.
Great, thank you, and it's nice to see a few familiar faces there. Hello to everybody whose paths we've crossed. I wanted to just comment on a couple of things that built on the NAS surgical stadium that I co-hosted with David, just from the surgeon's perspective in the audience. You know, first there's a continuum of spine surgery demands, and one continuum is just the site of service, everything from inpatient to outpatient ASC. The second is the continuum of case complexity. Again, everything from the highly complex scoliosis cases, deformity cases that have been shown, to the simple, 1 and 2 level, interbodies with percutaneous screws. And then finally, I believe there's just this enabling technology continuum. And what I mean by that is, freehand still uses, quote, enabling technology. It uses C-arm. You've got navigation and guidance technology, kind of traditional stealth, which is still pretty complicated. It brings in a lot of technology external to the patient, but maybe just not as complex as a robotically driven, which would represent kind of the kind of penultimate, synthesis of all of these continuums. The VUZE platform, in my humble opinion, sits perfectly in that middle tier of the continuum. It's a complement to existing enabling technology platforms for cases for surgeons who wish to use a C-arm driven instrument guidance. The next thing I wanted to just touch about, I've been on the whole conference. It's been amazing, and compliments to all of the faculty. I've learned a lot, a ton, quite sincerely. But the issue of all of these papers citing, frame shift errors and what that drives, and in terms of just stopping your workflow cold to the worst case scenario of causing a complication, this is non-existent as it pertains to the VUZE platform. You could see there's no there's nothing in the way. There's no reference frame with which you have to rely upon. And then lastly, the other part of this conference that's been extraordinary has been the focus on minimally invasive, coupling robotics, coupling deformity surgery with MIS technology. And as it pertains to the VUZE system, as it sits, as I said, I think it complements an enabling technology platform in a way that it's the workflow. There's no reference frame to mount, specifically or separately to the spine or the iliac crest or to a spinous process. Number 2, there's no landmark registration that you have to go through. You don't have to find a part of the spine to open, if you will, and land a spine anatomy check. And then lastly, the learning curve, 2 cases probably. It took me probably 45 minutes when I was in Cologne, Germany, to get the workflow down and then just kind of integrate it in as obviously all of us are very familiar with C-arm based workflow. So we appreciate the opportunity. I'm enamored with the technology. I just find it elegant in its simplicity, and hopefully we can answer some questions from the audience.
Hello, Paul Slosar. How are you? Welcome, and thank you for your time here today, you and David. I'm kind of blown away by all this. I'm looking at it and I'm trying to understand. There must be some complicated mathematics that I'm just not, I'm not at that level or something.
It's just a CRM and a PC with software. That's all.
And I just want to know more about it. That's the whole thing. You've just tickled me a little bit to where it's like, okay, how and where am I going to use this for each of the procedures that I'm thinking of, all the things that we do as spine surgeons? I can imagine all kinds of things. And I've been saying, we need localization and navigation technology that does the same thing, that we can go do a laminectomy, a microdiscectomy, a fusion. I don't know if it applies to the front of the spine or not, but I do a lot of artificial discs, and I'm just thinking, I don't think I'm understanding exactly how all this could be applied. It's kind of based on the vertebroplasty, kyphoplasty.
Yeah, 100%.
That's where
I was going to say anything that's transpedicular, right, or anything with bone anatomy, SI joint, the relieving procedure, the pain procedures, placement. We actually were talking with some of the guys at NAS who wanted to get better sense of where their artificial disc is placed, medial lateral from a centralization perspective, especially in an anterior lumbar where it's hard to get straight up centralized. But the thing that's hard to put into that presentation is this is basically a C-arm overlay, and the key thing here that is very differentiating, it's C-arm overlay onto a CT scan. So you can get a CT pre-op, you can get a CT intra-op if you have an O-arm, or you can get a CT intra-op with a 3D C-arm scanner that are coming out now. These are becoming much more prevalent. So you just spin with your C-arm. You don't need an O-arm to do a localized spin. But the thing I wanted to point out is the VUZE navigates off the tip of the instrument. It's really where the tip is. Everything else, navigates or references from the handle, because that's all it sees is what's external. So the fact that where the tip of the instrument is on real-time overlay, I think just adds another layer of elegance to it.
So you need both K-wires put in to be able to get three-dimensionality. Is that correct or not? I'm getting a head shake no. I'm just trying to understand
our current FDA clearance is for single tool, minimally invasive thoracolumbar fixation coupled with fusion, kyphoplasty, vertebroplasty. All of that is single tool. What you saw in the video is an extension, how we can guide two tools concurrently, which as far as we are aware, and I've been in navigation for 30 years, and no other navigation technology can achieve.
Wow.
So Dr. Slosar and Mr. David, thank you so much. It's Terrence Kim. I'm sitting here with a couple spine surgeons. Our heads are scratching, but I'm trying to understand this better. No navigation camera, no navigation instrument, throw away all that junk.
Wonderful.
And,
no reference, no calibrations.
I put a scalpel right down to where I want it, and then it will give me a 3D onlay of what it is with an AP and a 10-degree off. Is that what you're telling me?
That is correct. Basically, on the 3D scan, we just plan the insertion trajectories and get the dimensions for whatever we want to insert automatically. And then when you shoot a first X-ray, you get the planned incision site projected from the current viewing angle of the C-arm. You make your incision as small as possible, insert a Jamshidi, take a second X-ray at least 10 degrees apart, and then you get the axial and sagittal cross-sections. And that process that I described takes 2.5 seconds. And as you said, there are no cameras, markers, references, calibrations, etc.
That initial trajectory, the first 00 X-ray, that trajectory that the software figures out, is that based off of your ideal trajectory that you preset on the CT scan?
We always show you where the tool is relative to your planning from the current viewing angle of the C-arm.
Okay.
And the
planning is always projected on the current X-ray.
Yeah, and Terrence, the pre-op planning basically once you have your CT, be it from loaded already or you spin and it's integrated, you basically get a picture like we're traditional any navigation where you say I want my screw to go here, I want this screw to go here. Once you do, if it's 4, 6, 8 screws, you label them, and then the funny thing is since it's a CT, you're just doing the pedicle. You're saying I'd like it to go down the pedicle this direction. The VUZE will then extend you to your skin, and it'll tell you that little circle at the beginning is where the incision starts, which many of us who've done this or taught a lot of fellows, we always start too medially typically with our incision. So it brings you from a skin incision all the way down to where the tip would end in the vertebral body.
And because we focus on a targeted vertebrae, we don't mind the prone supine issue of pre-op CT versus intra-op X-rays. That does not affect our accuracy. We just focus on the targeted vertebra. We don't mind tools bending because we track the distal tip, and we don't mind reference shift because we don't have a reference.
So this is, as I'm trying to understand this is kind of dynamic navigation. In other words, with the current systems we have with navigations, it's static, and that's what causes you to put an instrument straight into the canal because you're following a false path. So
Yes.
what you're doing is this is almost like 7D with light projections. You're using X-ray. So every advancement of the instrument, you get a shot, it'll show you where you are on the CAT scan. You're like, whoa, I'm too medial, adjust, get a shot, and then go in a better place. Like it's that kind of dynamic registration, right?
That's true. And what got us started, our team has previously developed 2 standards of care in guided bronchoscopy and guided coronary catheterizations. What got us started here is that we stumbled upon spine surgery and we asked ourselves, how come almost 30 years after optical navigation has been FDA cleared, only less than 20% of the most complex inpatient surgeries are navigated? How come MIS is only 20%? How come only 200 ASCs do spine, et cetera, et cetera? So went out and talked to surgeons, that was 7 years ago, and surgeons said, look, most of our cases are 1, 2 levels. We like X-ray because of its simplicity, affordability, tool neutrality, small footprint, et cetera, just give us the cross-sections, the axial and sagittal views. And if you can do it without lateral X-rays, only with APs, that's even better because nobody likes laterals. So those were the guidelines, and that was the road we marched along.
Any C-arm machine, or it has to be the C-arm that your company has?
No. Our FDA clearance is for C-arms currently from GE, Siemens, Philips, and Zeem. The only limitation currently is that we focus on flat panel C-arms. We haven't yet dealt with the image distortions of the old image intensifiers that are gradually fading out.
Flat panels. I see. And then, so I see this as a problem with us in arthroplasty all the time, not knowing if our implant is exactly where we want it. Sometimes you get a fluoro to confirm where your implant is on the AP. You get a CT scan down the road, and it's way off to the side and rotated. And you're like, well, the fluoro looked like it was dead on. So I see this as an extremely compelling thing for arthroplasty placement.
Slosar, did you want to add anything?
Yeah, no, we had a couple of people come up to us after that surgical stadium, Terry, and say the same damn thing. Yeah. So, I mean, and these guys, they just need an outline of the instrument, right? If you're going to use whatever the dimension of the AP, side to side dimension depth of the instrument, that's what you guide to, right? And you can recreate that pretty easily.
Okay, what are the prospects for developing beyond axial imaging?
Okay, Emma, can you clarify the question, please? We mean beyond axial imaging. Do you mean beyond the current type of procedures?
Other orthogonal planes, coronal and sagittal.
Oh, we currently provide axial and sagittal, but our software can do any plane that you want to do. Also, the technology is not limited to spine. Our software knows nothing about vertebrae. The technology, as long as there are patents, is applicable to any skeletal portion.
Okay, it's all pre-planned. What's trackable? Is there something live that's trackable?
No, every time you acquire an X-ray, the software automatically detects the distal tip of the tool. We take a few millimeters backwards in order to show you the real trajectory, not the one you extrapolate from the proximal side, and show you the cross sections. Currently, we show axial and sagittal, but we can show you anything you want.
Disposable. Disposable.
Yeah, okay. I want to learn more. I'm fascinated. Totally fascinated.
Yeah, so that's why I got on a plane and flew out, because I couldn't believe
I
it
know.
either. So
I want to go to Cologne.
I tried everything I could.
Is that where I go see?
It was pretty simple. Yeah, it was wonderful.
No, I've done that. Whenever I see something I like, I go see it.
Okay,
I went to
may
Sao
I
Paulo to
just mention
meet-
again that we're looking for 1 or 2 initial pre-commercial US sites. I'm David T. at VUZEmedical.com, and if you go to our website, the info at VUZEmedical.com gets to me. So you're welcome to write to me.
So this is also a question, just as we try to put everything together. This is software, and clearly not holding. Huh?
Where is that screen?
Oh, that viewer that's behind you on your right shoulder on your virtual background, is that the unit that needs to be purchased in order to run it?
Yeah, all you see is a PC in a nice casing. It's an off-the-shelf PC with a strong NVIDIA graphic processor and a large touchscreen and an isolation transformer. It's all off-the-shelf hardware. It's basically a PC on wheels and a touchscreen.
And then just from and not holding either of you to it, but like from a cost standpoint, what's the U.S. equivalent ballpark of some thing like this?
Pricing has not been established yet. Basically, any imaginable pricing scheme may be applied here because the hardware is just a PC and a monitor. But currently, we're still in a pre-commercial phase, and that's our current focus.
Can so you're saying a gaming laptop can run this, or it has to be?
Well, basically, it's an NVIDIA GPU graphical processing unit whose main use today is gaming and cyber, I guess. And we're the beneficiaries of that. The act of acquiring an X-ray and immediately generating the axial and sagittal cross sections 7 years ago when we started took an hour. Today takes 2.5 seconds. And that's not only thanks to our progress in developing our software, but also thanks to NVIDIA.
Okay. Thank you very much.
Awesome, Paul.
Good to see y'all. Thank you. Great course, you guys. Appreciate it. Thank you.
Thank you very much.
Thank
See you
you for
later.
this intriguing concept. Thank you. All right,
Aesculap.
we're moving on to Aesculap and the robotic exoscope. Ryan?
All right, let's try that again. So again, I'm Ryan Mancini. I'm the Group Product Director for Robotics here at Aesculap. I'm joined by Stephen Hagan, who's our Seattle area neurospecialist. And so today, going to introduce all of you to our Aeos robotic exoscope. So for those of you in the audience who may not have had the opportunity to use an exoscope firsthand just yet, so a quick orientation here, right? So no oculars at all, 100% digital visualization system married to our robotic arm. We have multiple monitors. We have an integrated 26-inch monitor, and then both here today, we have our 55-inch monitor as well as available a 31-inch monitor on roll stands. And so what that means, able to configure multiple monitors in the OR depending on both the physician and procedure needs. And so Stephen's going to kind of walk us through some of these controls here. Obviously, we're here to talk about robotics, and we're going to give you, let's start with the robotic features of Aeos. So in order for us to make some repositions, Stephen can go ahead and grab one of our unlock buttons here. We can make large gross readjustments with just the press of a button. The robot does the work for us. And the idea is you don't have to hit a bullseye as far as what you're trying to visualize here, because where the robot really starts to stand out is some of these finer micro movements where essentially we can move in the X, Y, and Z planes and really get a precise precision as far as exactly what you're trying to visualize. And then from there, we're able to do some semi-automated robotic repositioning. So with the press of a button, we can, instead of going from X, Y, and Z, we can now pivot around a fixed area of interest. So we can rock side to side, front to back, and really start to put the scope in some aggressive angles. And now, since we've decoupled from the oculars, now you're able to really take a vantage point that would be challenging, if not impossible, with a traditional optical-based microscope. And so what we've seen from our surgeons who have adopted this technology is that ergonomics may not have been the primary motivator for moving to an exoscope, but one of our surgeons likes to joke that now, after performing an ACDF, he no longer feels like he himself needs an ACDF, right? Because of being able to have that direct line of sight to the monitor and no longer be affixed to the microscope, and therefore the device is no longer dictating the ergonomics to you. Another area of robotics that we can lean into here is what we call setting a waypoint. So it's like dropping a pin on your GPS. So Steven's going to set a waypoint there. If we move the scope into a different position, and then with the press of a button, we can recall that waypoint, and the scope will move exactly to where it was before. It saves its zoom, it saves its focus level, it saves its positioning. So it really is like hopping in your DeLorean and going back in time to back to where you were previously. You can set an infinite number of waypoints over the course of the procedure. So for example, we have some of our users who they'll set a waypoint in between levels. They can pull the scope out of the way, press a button, and then the scope returns exactly back to where it was before. Muscle memory probably could have got you very close. But again, the robotics, that's what gives us the precision. Outside of spinal surgery, for cranial surgery, we have some of our users, for example, in an aneurysm, in a complex case, they may set a waypoint at the front of the aneurysm. They want to take a look at it from the rear, press a button, they can then quickly return back to where they were looking at previously. So these are just some of the examples that if this were, say, a non-robotically based exoscope, you'd be relying on the human brain and the human hand to make those same movements. Again, robotics gives us that precision, it gives us that reproducibility. One of the other interesting things here, since this is also a fully digital platform, so the visualization is digital, it's a software-based device, is that the hand grips that you see there with the different controls that Stephen was just interacting with, we can save the configuration individual to each user. So for example, if a given surgeon had commands that they prefer for one procedure over another, we can set an infinite number of surgeon profiles to either make the controls as complex or as simplified as the individual user prefers. And again, this is just, I think, it's a little bit of a tired analogy, but if we kind of look at our cell phones, right, we kind of have come to expect that the user experience will continue to evolve with the technology that we use, and that's very much the case here, where we're constantly rolling out software updates that are both improving the interface, improving workflows. So very much the expectation is the device that you have today will not be the same in some shape or form a year from now as far as its functions, its capabilities, and how we interact with the technology. Speaking of the digital visualization piece, a couple other examples we can show you here. Aeos can essentially act as a digital receiver. So for example, we can do a picture-in-picture to pull up, for example, while we don't have another navigation source right now, as you can see, we have a split screen on our control monitor and on the big monitors as well. And just with the press of a button, we can pull it up. And the press of a button, we can pull it off screen. So the idea is pull up supplementary information when you need it, and then pull it off monitor when you don't. Similarly, for example, if we had a neuroendoscope, we could also pull in that same digital feed as well. Another example of this is we can add a digital aperture on screen. So if we're in a MIS procedure, right, and we want to black out the information that we don't need, while it's not changing the actual image itself, right, we don't see there's not a black circle on our anatomy, but on screen we can digitally augment what that looks like. And again, this is just sort of scratching the surface as what we can do with a digital image as opposed to with an optical image. Lastly here, and while our model here won't quite do it justice, we have multiple imaging modes, so we can also essentially tweak the color set that you see on screen based upon the preferences of the surgeon as well as the anatomy on hand, and again, being able to augment what we see on screen versus what the naked eye could see with an optically based image. Another piece, well, I do want to highlight, well, it falls a little bit out of the scope, no pun intended, of our topic here. In the cranial neurosurgery space, we do have both blue light and ICG fluorescence. And so while those themselves aren't novel technologies, being able to have them in full 3D, and also we're able to throw additional white light on those images, it allows us to spend a little more time in those fluorescence modes than you would typically, right? Obviously, it's a little bit brighter in the room that we have here, almost sort of looking a little like sodium fluorescein, but the idea is by being able to throw more white, we can work in these modes a little bit longer. So again, kind of reinforcing the benefits of this a digital image as opposed to an optically based image. All right, so I think a couple other pieces just kind of tie this all together, right? So I'd say that our viewpoint is that exoscopes, both the current generation and their successors, this is very much the direction that surgical visualization in the neurosurgical space is headed. So we're deeply invested in both the current generation as well as subsequent generation technologies, because we feel that the benefits that robotics provides, again, bringing us back to the reason why we're all here today, as far as both automated and semi-automated movements, the precision that provides, and then as well as really the untapped potential on that digital visualization piece, as far as being able to improve the user experience and workflows, but also be able to provide additional insights to the surgeon on screen that traditional, more analog-based technologies really essentially have hit their ceiling on. This is where we see things are going to continue to expand, especially right with AI, with machine vision, with augmented reality, as more and more of these technologies are converging with one another and more finding ways into additional devices. This is very much where we see this both platform and, as I mentioned, subsequent platforms expanding as we go forward here. I think a little bit ahead of my finish time here, so I guess moving to the questions.
That's cool stuff. I have to ask the question about a lot of exoscope stuff is that there's work in the 3D world. Where is that? Are there thoughts of that in the Aesculap world?
I'm sorry, could you ask that one more time, please?
Are there interest in 3D?
Oh, yes, I'm sorry, thank you very much. So yeah, so this is a 3D platform. We just, for the purposes of this presentation today, we have this set to a 2D image, but yes, the idea is all of our monitors are 3D when we're actually using this in surgery. Okay,
that would interest me. That interests me a lot. So any other comments from audience?
And I'll clarify that slightly too. It's full-time 3D, so I know there's been some other technologies that have had limitations as far as 3D at one, it'd be at a certain magnification level for 2D, a different magnification level for 3D. This is 3D regardless of your mag.
Dr. Kim.
Yeah, no, my biggest problem are sometimes those MIST lifts under the microscope. That tends to be a little problematic. When you're trying to put in the interbody cage, the microscope is pulled way out laterally. You're almost putting them in with your hands fully extended to try to get that. So the scope blocks you. So I find a lot of value in this. Tell me, price-wise, how does this compare to a microscope? Because I imagine this is kind of a substitute for the microscope, correct?
Absolutely, yes. A substitute for a microscope. So I'd say what you're looking at here, the fully loaded package, the big monitor, the fluorescence modules for cranial neurosurgery, that whole package for under $500,000, which is going to be a substantial savings compared to fully loaded platforms for some of the other products on the market.
Awesome stuff.
And I'll say too, from a lateral positioning perspective, essentially what we can do is we also, since of decoupling from the arm and the robotic capabilities, we can invert the arm. So essentially, as you see the elbow up here, the elbow can revert down, and essentially the camera can sit at that more of a chest level. I was actually just in an X-lift the other day, and the surgeon couldn't believe how well he could position himself, or he no longer felt like he was having to reach so far around from his microscope. So from a lateral perspective, there's definitely some great advantages with the exoscope.
All right, great stuff, great stuff. Appreciate you guys coming. It's
Yep, thank you.
exciting to see the advances. Okay, moving ahead with Stryker and the Mako spine and Copilot robotics. Where's Sean? Sean on?
I'm on the screen. Can you hear me?
Yes, we can.
Perfect. Thank you very much. I appreciate the opportunity to attend the meeting, and I appreciate the opportunity to showcase some of the technologies that are recently coming to market. I'm going to share my screen here. Hopefully everybody can see my screen.
Yep.
I wanted to speak today about the Q Guidance system with our most recent spine guidance software launch, Spine Guidance 5.0, and I'm going to be speaking about our Copilot platform as well. And these technologies, if you haven't seen them already, are available to be evaluated in the evaluation area that you have set up. So our Q Guidance system, this is our 4th generation platform, and we were very purposeful in calling it a guidance system as opposed to Nav4. And the reason for that is this is really the computational center of the ecosystem that we're developing to support not only technologies like Copilot, more traditional navigation steps, but also robotic arm technologies as well. It has 2 PCs. One is dedicated to the software application. One is a real-time PC delivered with the intention to reduce latency for the software as well. We also have 2 touchscreen monitors, one for an operator and one for the surgeon in the field. Our camera, which I'll talk about more in a moment, is also a 4th generation camera, our FP8000 camera. And this is something that we do a little different than what's on the market today. We don't use an off-the-shelf camera. We actually design and manufacture the FP8000 ourselves. And the reason for that is because of the intention of our roadmap and the capabilities that we want to enable surgeons to perform. But we also want to leverage active and passive tracking capabilities. We know that those that have used navigation systems have experienced frustration with maybe blood or other fluids getting on passive trackers. Our active tracking technology, in addition to being very active and very precise and accurate, it's also less susceptible to interference due to fluids. It also allows for two-way communication between the sterile field and the system with smart pointers and other smart instrumentation as well. And then with our cranial guidance platform, we also enable a 3rd mode of tracking with EM tracking as well. So a few things I want to highlight here. The first one being that this is actually the Spine Guidance 5 software is our 3rd clearance. So our clearance on the platform, the Q Guidance platform, was first received in June 2022, and our first application was Spine Guidance 4. We followed that up in February in 2023 with Cranial Guidance for Q applications. And then most recently, in July of this year, we launched Spine Guidance 5.1, which is featuring the Copilot software. And then our most recent clearance is Spine Guidance 5.2, which supports Mako spine. So now what you have is a Spine Guidance 5 software that'll support smart powered instruments as well as smart robotics technologies. And with our Spine Guidance 5 software, really our intention is to deliver the benefits of imaging the patient in the operative position and intraoperatively, but reduce the time from image acquisition to plan execution. And there's a number of ways that we do that. We have smart segmentation capabilities. And really what the state of the art is today is to put a bounding box around each of the vertebral bodies and identify to the user that there's a vertebral body within that box. What we're actually doing is we're identifying the bony surface of each vertebral body. It's looking at things like the pedicle, the isthmus of the pedicle, and based on the screw family that you pick, it's provisionally selecting and placing a screw within the area of interest, within the vertebral bodies of the surgical area. What it's also doing is it's creating no-fly zones, and I'll demonstrate that in a moment. So it's putting a boundary around places that you don't want powered instruments to go, like the spinal canal, the anterior wall of the vertebral body, the exiting foramen, and the superior and inferior end plates. And all that is done automatically. Now, certainly the surgeon needs to go through, review, and approve it. But again, the intent here is to minimize the time from image acquisition to the time that you have a completed plan and ultimately execute that plan. So within the Spine Guidance 5 ecosystem, one of the product families is called Copilot. And what I'm going to show you here are 2 of instruments. These are 2 of the first, but I'd really like you to think about this extending to become a family of instruments utilizing different technologies. Now, one of the demonstrations earlier, it was mentioned that, really the preference isn't to have to stare at a screen while you're operating on a patient. And one of the ways to address that is through advancements in instrument tracking. So what you see on the screen here are two things. One, you see our Signature 2 high-speed burr with a 360-degree tracker. And really the intention there is to eliminate line of sight concerns, to maximize the visibility of this instrument and allow the surgeons to focus on the patient, not on the screen. And then the other instrument on the right-hand side is our ES6 driver. Here it's being shown with a screw attached. And what this enables is a smart stop or an automatic stop when the implant reaches the planned depth. So I'll show you an example of this on the video, which I'm going to play now. On the left, you can see that instrument goes into the zone. You have a stop zone located around the spinal canal. And one of the reasons for the speed of our camera, which is critically important, and this camera is up to 15 times faster than the off-the-shelf cameras used by market-leading systems. And you can program it to do a couple of two things. You can have it automatically stop. You can have it vibrate the foot pedal. You can step down the speed of the instrument, which is more of an audible cue, or you can have the system tone or have a visual signal that you've reached that boundary. With respect to pedicle cannulation, tapping, and screw delivery, similarly leveraging that plan, you have an auto stop. So when the screw is inserted and it reaches the planned depth, the insertion instrument will automatically stop as well. And as I mentioned, this is enabled through active tracking technology. This is an example of that 360 tracker. So you have 360 degrees of visualization with active LEDs. And when I say active versus passive, what I'm speaking about is those trackers have LEDs on them. They emit infrared light to the camera, as opposed to the camera emitting infrared light and having it reflect off a reflective fiducial. So as I mentioned, really, this is an attachment in a software edition to what is a market-leading powered instrument platform. So our Signature 2 high-speed drill, you have the 360 tracker. It utilizes, there's 10 different Elite Q attachment options, ranging in different lengths based on what procedure you're doing, which step you're performing, or surgeon preference and patient size. And then the other thing that we spent careful attention on is the instrumentation. When you have tracked instruments, sometimes those instruments can become heavy. They can become too long. And certainly in a spine procedure, we're cognizant of the fact that that can place undue strain on surgeons as they're doing these repeated steps day after day. So we spent a lot of time trying to reduce the length of the components that are used, reduce the size of the tracker, and ultimately make these instruments more ergonomically friendly. So with that, I'd be happy to answer any questions you have. As I mentioned, this is part of an expanding ecosystem. Spine Guidance 5 with Copilot, as mentioned, launched earlier this year. We are now also in a limited market release for Mako Spine. We've done our first cases with Mako Spine with good success. We'll continue to roll that in a limited market fashion for the next 2 quarters. Until full market release. So right now, for the first time, we're adding spine procedures for the Mako, and Mako to date has performed over 1.5 million joint replacement procedures. So we're excited to add this capability to that platform. I'd be happy to answer any questions that the audience might have.
Great. Sean, thank you very much. That's some exciting advances in some of these things, which I think have been needed a long time. And I have kind of a personal one I suggest to you and anybody else who wants to follow. It seems that a lot of our tools that we use are very long and they're made for one part of the body. Okay, and the cervical spine and thoracic spine are much shallower wounds. And so I think a lot of those things that you have this whole platform of your implants and all of your navigation things, it's just that they seem to fit the ergonomics in the operating room, and I'm not sure why nobody's ever done that out in the world there yet.
I agree with you, and I'll say we were certainly guilty of that with prior generations of our own platform. So, with that, as I mentioned, there was a concerted focus on that to make them light, more suitable to the procedure being done. I'll also say that platforms like Copilot, while our first application is in spine, and we're looking to extend that across other powered instrumentation that we offer within the Stryker enterprise, not only for spine procedures, but for other neuro and cranial procedures as well.
Dr. Kim.
Yes, so I was with Dr. Ross. We were looking at your Copilot and your Stryker system in the demo area. I was shocked by how the instrument could still be read even though it was completely blocked from the camera. I mean, that was insane, right? Like, we had the instrument and then I put my hand in front of it and it was still tracking. Like, how is that possible? What is it doing?
That's one of the benefits of, and one of the reasons that we designed our own camera. And I think the other thing too is that tracker that you're seeing on that instrument, that 360-degree tracker, is bespoke as well. It was purpose built for that. It's one of the benefits for being able to develop that organically and within the business. So it's something that we have expertise doing. It's something that we look forward to applying, but that's exactly it. Ultimately, one of the benefits of Copilot is that as you start to introduce these advanced guidance capabilities, we want you to be able to retain that tactile feel and that awareness and what you're used to feeling in instrumentation that you use today. So I think that's one of the beauties of Copilot, is giving you an instrument that you're probably used to holding, used to feeling, knowing what type of tissue that you're in, but providing that added layer of safety. And what we find also with respect to the warning zones is that sometimes if there's younger surgeons or fellows, it may be desired to have the instrument stop. That may be how surgeons start to use it initially, but very quickly they migrate either to the step down speed or vibration of the foot pedal. So it allows you, particularly if you're doing a laminectomy, for example, to go through, have awareness that you're getting close to having a frangible element when you get close to that breaking point, giving you a warning and allow you to proceed until you break through that element. You can break that fragment off. And then also, as we look at across the portfolio as well, these are obviously mechanical high-speed cutting instruments, but as we look at other potential for energy devices and things like that, these are capabilities that could be applied to those instruments as well.
I think that's what's the most exciting part of your technology, is that about 5 or 7 years ago, just the stay and hold screw was the only thing a robot could do. And to try to understand if there was ever going to be some kind of forefront of someone looking at no-fly zones in respect to decompression, in respect to autonomous robots that can protect themselves. So I think these are creative and extremely appealing solutions to creating that next level of robotic technology, or what you would call robotic 2.0 or 3.0 in the future. And I'm really excited about your company.
Perfect. I'm very happy to hear that. As the way that we look at it, we look at this as being an ecosystem in the truest sense. And that means that we don't want to take a single tool and make it do all the steps. We really want to align the right tool to task. And in some cases, that means a manual navigated instrument. In some cases, that means a smart powered instrument. In some cases, that means a robotic arm technology. And we also understand that that's going to change over time, right? With respect to surgeons' level of comfort. We've also spent some time today talking about the ASC, and we understand that there's different considerations in the ASC as well. If a surgeon's operating in an ASC and a hospital, we don't want their workflows to change substantially, right? They can pick the tools that are available to them in the ASC. They can pick the tools that are available to them in the hospital, but the software workflow is relatively the same. It just adjusts based on whether or not they're using robotic arm technology or not.
That's why they call it everything that's cool in spine surgery. That's this session. Sean, that's great stuff. I love the no-fly zone concept, and there's just some great innovations that you guys are doing. So thank you very much for being here. And
thank you very much.
Please come back. We'll invite you again in the future. We're going to move on to Brainlab. Krish Vigneswaran's going to talk to us about where they are with their Brainlab robotic suite and loop imaging technology, and I've seen some of their stuff.
And we have a Cirq in the back there.
And, yeah, thanks, Danielle. There is a Cirq system in the back. I urge everybody to go put the helmet on or put the glasses on and see this stuff. You've all seen augmented reality, but I think it's kind of taken it to a new level. So here we go. Krish,
right.
Thank you.
Yes, hi. Thanks for having me today. I'm happy to be here and present some of the great innovations that I've been able to do with Brainlab. Let me get my slides to show up here 1 second. So in 2020, the decision was made to go forward with, first getting a navigation system. But at that time, there was an idea of what if, robotics started to become a word that was thrown around a lot, and the concept of developing a robotics suite. There was some potential there in terms of ROI, in terms of marketing. The main thing was trying to figure out if we were going to go mainstream with things that are already established or try to something new, something that could be multi-purpose, multidisciplined, and allow us to innovate as well. The key things that we wanted to be agnostic to instrumentation, so we could use any type of implant as far as hardware, and also agnostic to the type of tools we're using, meaning we could use a Midas Rex drill or a Stryker drill or anything, any microscope, a Lycoscope, a Zyscope, and we wanted to just be able to navigate and kind of innovate with any device that was already in our accoutrement. And we also needed to be mobile, able to go into multiple rooms and to be able to be used with multiple beds. So at that time in development was the kind of the suite of things you see presented here, the Loop X, the Cirq, and the software that accompanies it with the Curve navigation system. Now the Curve system is used for cranial applications for our standard stereotactic guided resections of tumors or lit and such. But in building a hybrid robotic suite, we were kind of following the precedent of what's been done with our open endovascular suites, with our iMRI suites. We wanted a spinal robotic suite that would be very efficient, that the staff could become very familiar with, be reproducible, and be mobile into different settings, different rooms. So software, I won't belabor the point. Lots of groups today have presented software, and it's always getting better. I think the pre-planning ability of the software is key. In clinic, we have our screens up. We show patients exactly what their hardware is going to look like on their preoperative images and CTs, and then the ability to auto register once you do the intraoperative scan allows us to merge the preoperative plan scan with the intraoperative scan and look for subtle changes, which is especially important in our prone lateral and lateral cases. I think having the ability to plan everything ahead of time rather than having to plan in the OR allows you to kind of account for some changes, and also to think about things like where the array can go, where collisions can happen, and be proactive about anticipating things so things go smoothly in the OR. Again, the software is getting smarter by the year and by the iterations with auto segmentation, auto labeling, auto measurements, but those all come with nuances, and as surgeons, we are responsible for detecting the variances and adjusting and accommodating for those things, especially in the spine oncology world when performing separation surgeries. It's very useful to be able to merge the MRIs and the CTs, create models, and develop that. The navigation platform itself, the Curve, again, we use for both cranial and spinal navigation, so it can be used across disciplines. I'm sure everyone's very familiar with it, so I won't belabor the point on the Curve. Microscope integration has been around for a while, but again, it's continuing to improve. The thing we're really here today to talk about is robotics, and I would say the Loop X is actually a robotic imaging system. It has the ability with its large gantry to come into the room on its own. There's not a tech pushing this thing around. It will drive into the room with the panel. It can allow us to do some off-center imaging. It can memorize positions, different views that we need, and store those positions, recall those positions, along with recalling bed heights. And it's not fully autonomous at this point, but I think that's the direction it's going. The newest iteration of the Loop actually has its own camera on it to help it become more autonomous, more like a Tesla, if you will. And so that it helps just seamlessly in the room. When you have sometimes turnover in X-ray technicians that are using these devices, these actually start to kind of know more and are more helpful, and the surgeon can actually integrate easier with the machine itself to help with optimizing and streamlining the imaging process. The Cirq, which is the true robotic arm, is I think a really efficient tool. It's steady, which is, the key thing is that's moving us into robotics is with percutaneous placement or open placement of screws, is we need something that will be very steady once we've identified our landmark of where the screw is going to go. So steady, in fact, that we've used it to do C2 pars pedicle screws, DEN screws, and it's very accurate in its placement of S2II screws. It's small, it's ergonomic, so we're able to get in weird angles to place those sacral screws, and it's implant naive. So we can use whatever instrumentation we need based on what the surgeon needs and what the case calls for. And interestingly, it allows us to improvise. It allows us to do things in semi-open manners where we keep some portion of the back closed, the fascia intact, some part of the fascia open, and so we can put screws in percutaneously and open. In prone lateral cases now, we are actually trying to get our lateral dilators in using the Cirq to help with alignment and to get us directly into the disc space, and playing around with that as well. So I'll show you some real world things here in just a second, but ultimately the robotic suite is the combination of the Cirq, the Loop X, and the navigation system. So in 2022, we had the first robotic suite in the US, and we're able to deploy all three of these tools in an OR setting to allow us to push the boundaries on that. So here's kind of our real world now, how we set it up with 3 HD monitors in the room so that everyone's looking at what's going on both on the operative field and from the navigation standpoint. We have the Loop X, the Cirq, our diving board table with radiolucent head frame, and the curve system set up with the camera. So the way the room flows is that we have the patient here, heads towards the door, feet towards anesthesia, the diving board setup, navigated scope, the loop that can drive into the room, do your imaging, and then leave or park itself by the wall once the scan's required. It's then auto-registered and merged into the preoperatively planned scans, and so we have all the different devices ready to go. So again, the types of cases that we're doing, spine and cranial, but from a robotic standpoint, what we're able to do is, and I'll give you some examples of some standard cases, a standard TLIF or DGen case. The preoperative planned screws are then loaded into the system intraoperatively. We merge those with our new spin and new scans, and we're able to then move forward in a timely fashion. I know that y'all have been here for a long time, so I want to get to some of the real world examples. So here's a pathological fracture from a multiple myeloma patient that we were addressing. And so when the planning portion of the case starts, let me see if this video will play here 1 second. All right. Right. Like I was saying, the 3D planning portion of the case is done preoperatively. It's a good tool that we use when working with our residents, and also when educating patients about what we're planning to do in terms of giving them some insight into what the actual process of the surgery is going to be like. The software does predict, as you can see, what the screws may look like and where they may go, but then the final touches are done by us. So once we've planned these screws out and decided on it, then we move into the OR and we're actually doing the surgery. The scan that's acquired is then merged. But this part of the software allows us to really think about in bigger constructs where heads will align, where we could run into problems with the orientation when we're looking at angles and balance and all the other things that come along with doing larger constructs. For other pictures. Again, the loop here coming in to proceed with acquiring the image, then us being able to use incision planning, which is a tool that aligns a laser directly on the patient's skin so that we can minimize taking extra shots to kind of mark out our incision and our plan of where things are going to go. Sorry. System's lagging just a second. All right. So the picture that was there before was our use of staples for fiducial mapping and things of that nature. But again, not clicking, but okay. Again, here more of some kind of ideas of the workflow of when we get to, so we've marked out the incision, we go ahead and drape, we then come in with our navigation system, acquire our intraoperative scan. You can see there the Cirq that's laid off to the side. That is then going to be integrated later into the screw portion of the case. But so workflow and design of the room and are all key things in this process. And so being able to optimize that is really where reproducibility comes into play, because there's so many different people that are involved in the whole process of these cases, and those people turn over and change. So everything that we can control and standardize helps make sure that that the surgeon's day goes smoothly. So here's one of our residents just kind of ensuring accuracy with the pre-planned screws, and then we proceed from that point with the cases as standard. Forward here, and here he's using the Cirq for placement of those pedicle screws, and it's a very good tool for them to use to first in their mind's eye and using navigation, understand where it's going to go, but then in real time also have the nav there to help them as well. All right. So the one benefit of this system we found is that it's agnostic to tools. So we're navigating a lot of different instruments now, navigating cobs, dilators for retractors, various drills, drivers, taps. So this allows us to kind of innovate. So here I'm using in the prone lateral cases a cob instrument. And so you can see here how we're able to navigate a dilator to the area of interest on the bottom left corner, pass that K-wire into the area of interest, verify with an X-ray that it is where it needs to be, or navigate a cob instrument across the disc space and performing this thoracic corpectomy. So what we're working on now is that bottom left panel where I'm using my hand to get the dilator there is to get the Cirq to do that move. And that's going to be robotically assisted lateral placement of dilators in those cases. But the navigated tools in these prone lateral cases are awesome. Really gives us a lot of confidence in proceeding forward with these corpectomies. We're always using X-ray to confirm. I think that's never going to go away. But I do think a lot less shots are taken in placement of the dilator. A lot less shots are taken when passing instruments across the disc space and performing these procedures. And we're able to move forward with that. So this is not a talk about prone lateral cases, but navigation does allow us as two surgeons to work simultaneously. One person working on the corpectomy side, one person putting in the screws, all navigated. These low-profile systems that are mobile allow you to do that efficiently. So two people can be working with various navigated instruments with less retractor time placement and be more confident with the resection. And so some of our films from that example case. So again, with placement of difficult screws and weird angles, S2AI screws and such, the robotic system is very helpful in making sure that it docks appropriately in the right place, that it holds firm in the right place, and allows for accurate placement with these very large screws that can sometimes skive or jump off the joint. So that's very helpful in those types of constructs and big cases. So kind of a variety of different cases that we've all done using the robotic system, the robotic suite now. So I think it's a very effective tool for these larger cases and even for smaller things too. For posterior cervical foraminotomies even, we've used the robot to help us dock in the correct position and then just put the tubular retractor down and perform a small case like that, but it's still technically robotic guided or robotic assisted. I'll leave, and it has cranial application as well. So in our retro SIGs or in places where you have a hard time doing registration, this will allow you to acquire your images with the CT scan, merge with your preoperative scan automatically, and then you don't have to worry about crawling under the bed with a pointer and doing registration in that manner. So auto registration feature is very helpful in cases where the positioning would make standard registration difficult and where accuracy is very important. So It's kind of examples of how we're, the cranial application of this software is still, for most of us, a good at least 30 to 40% of what we do as well, in addition to spine. So thank you guys. As they said, in the lab, the Brainlab team, I believe, has their planning software, their navigation software, their mixed reality, the Cirq, all in the lab to check out and test out today.
Krish, thank you very much. Can you hear me? That's a great presentation, and Brainlab's always pushing envelopes, and I love some of these things. So, we have any questions? If not, we're going to keep moving ahead. Anybody out there? Okay. Thanks again, Krish. Terry Kim is going to team up with Ken Metcalf and talk about the Velys spine robot. Thanks. Thanks, TK.
All right, last talk, guys, right? Last talk, Daniel?
Last talk.
Can everyone see my screen? So today I'll be talking about our next generation robotics. We've been kind of building up to this. There's a lot of cool technology that's coming through, but this is something that's currently happening now. The next generation robots are here, and Johnson & Johnson is certainly leading that charge with their Velys robot. These are my disclosures. Going through always the history of it, this talk about next generation robotics is not a contradistinction or diss on the robots that are currently here. They all have done extremely well. They've paved the way for the additional next generational stuff that we want to do as spine surgeons, but just as an homage to guys like Pat Johnson, who were around in 2004 with the Spine Assist, all the way to the Renaissance, the Mazor X with the Stealth Edition, Globus Excelsis, and Celsius, and the Cirq, which we just heard about. So at Cedars, we definitely have had a robust experience in using the robot, and whether it's MIS, deformity or degenerative, it's definitely not going away. All places of the spine, you've seen the robot being used today: trauma, tumor, single positions. The one thing I haven't heard today is where to use robots for arthroplasty.
You've done it, actually, your buddy, Dr. Perry.
Sure. But ultimately, the reason being there's copious amounts of data to support its use, which I'm not going to belabor. But the question is, what is next? What are we looking for that's reasonable, not robots that can watch your kids or do vacuuming. You're looking for, first of all, a robot that, again, is approachable. We all live in our ivory towers at our academic centers, but you want robots where the novice to the expert surgeon can come in and immediately utilize. You want faster robots. If you've seen today, these robots that are coming in, it's a very slow, kind of deliberate movement, very not easy to move out of the way if you want it to be in a different place. They're very static, so they kind of hold one position. You're certainly always looking for better accuracy and anything on the margins that might help the surgeon to stay accurate. And now what I'm talking about is, and what I've been harping about all day, is dynamic tracking. Any robot that can assist the surgeon in doing what they want to do instead of the surgeon trying to compete against the robot to get the proper job done. And so essentially what's called an intelligent arm. You're looking for easier user interfaces, quicker workflows, and these are just some of the attainable wish lists that I've been looking for the next generation. And so J&J came out with their new Velys robot, which is commercially available. It's FDA approved. It was FDA approved in June of 2024, launched several months later, and Dr. Ross tells me that they are one of the first centers to purchase and use, so we'll be looking forward to her experience next year. It's the first active assist assist robotic platform. So in other words, it is not static, and it constantly moves and works with the surgeon to get the job done. This robotic arm is 7 joints. It's made in Germany by a company named KUKA, designed in France, finished and completed in the United States. It's the same company that makes those Tesla robotic arms. So a lot of those early robotic presentations that showed the Tesla robot working on the Tesla cars coming through, and when you realize that the first generation robots weren't really like that, it's the same company that makes those arms. The current Velys robot is their first medical grade LBR KUKA robotic arm. So a lot of technology from other industries built into this robot. So this is a true kind of commercial robotic arm that we're pulling into the OR through J&J. And ultimately, the idea is that it's an active assist robot. It's the future. I think all the next generation robots will follow in this step. And what active robotic technology really means is 4 main pillars. Manual manipulation, so the robot has to be smooth, fast, get out of the surgeon's way. It has to be able to help the surgeon with trajectory assistance. It has to have adaptive tracking, meaning that it can move around the patient and sense changes without the surgeon having to press a pedal. And the screw release mode, which we'll get into in detail. But a lot of these highlights, I think, separate the Velys robot from all the current ones. Because all the current arms are static or set trajectories. So you decide where the robot goes, and it just stays there. And that's not what we want to see. We want to see robotic arms that can adapt. So in this kind of video, and by the way, we'll virtual feed to Raynham, Massachusetts to actually show you the robot arm after my talk. So I won't speak too much longer. But the Velys arm, when you move, let's say the robotic arm goes into the surgical field. You don't like it, the elbow's in the way, that's not exactly where you want it positioned. The surgeon can actually move it out of the way, and instead of old robots that kind of find the same trajectory back to its obstructed position, it will literally calculate a new way, a new algorithm, or through its algorithm, a new pathway, and say, okay, you didn't want my elbow in this way. We're going to try to get the trajectory from a different perspective. And that subtle kind of change in the way the arm moves and thinks helps to find ideal positions and to, again, assist the surgeon. From an adaptive tracking standpoint, this is you'll see this better in the virtual or in the model or in the Raynham lab today. If the patient moves, the robot moves. So any kind of, with the reference frame attached to the patient, as you can see, if the anesthesiologist accidentally adjusts the patient, accidentally pushes the buttons, or the patient actually moves, the robotic arm tracks that sense. So if the patient moves, the Velys arm adjusts to a new position. It actively tracks the patient reference frame in all planes real time. So you're not, again, the Globus robot also kind of does this, but you have to push the button. If you don't notice that there's a shift in the patient, the robotic arm does not necessarily, you have to push the pedal in order to recognize that. But if the patient moves, in the words of Ludacris, the robot arm will move as well. From a trajectory, now this is a big one. From a trajectory assistance, the Velys arm actively holds trajectory. It is the answer for skive, for patient soft tissue pressure, and instrument weights. If you've ever used any of the robotic implants, sometimes you lean a lot because the instruments are wired or the battery is heavy, and that leads to a lot of inaccurate trajectories. What this video doesn't show well, but what's going on when you actually use it is it's holding your position And if you lean hard on the lateral side, the robot is actively giving a medial trajectory or a medial pull to keep you in line. And so that idea that there's a skive or there's a lot of soft tissue for those open procedures, the high thoracic screws with the soft tissues in the way, the robotic arm hopefully, on cue, there's the audio, the robotic arm will counterbalance or counteract that. And the common metaphor is the Tesla lane assist, in that when you're on an automatic trajectory with your Tesla, if you're starting to veer out of plane or you're starting to get into the outsides of the margin, the car will gently give you a nudge back into the center. And that's what the robotic arm does, is it keeps you accurate. And this is a pretty big game changer in terms of active movement. This screw release mode, if you do a lot of robotic trajectories or robotic screws, what you notice is that as the screw goes deeper and deeper, sometimes it catches in the bone, but the robot is static. And so it will actually tweak the spine as you're inserting the screw and will create some kind of problem. Or the screw will get lodged into the human with the robotic arm holding it in place, and it's hard to pull everything out. There was one episode where I yanked it so hard that the robotic arm disengaged and we had to respin. So what is interesting about the Velys robot, and this is something that they've thought about a lot, is as the screw is going down about 80% of the way, it relaxes and it gives the surgeon that tactile feel that Kirsten wants and Pat Johnson wants, that tactile feel that the screw is going down the way you want it. And so that's kind of new because it allows the surgeon to avoid being in the wrong trajectory, being pulled or pushed in the wrong way. And I think that's kind of very intuitive and nice. From a UI standpoint, the Naveed and Michael and Raynham will go over this, but their UI, their user interface, is extremely friendly. It's very graphically oriented, and one thing about the UI is that from any point on one screen, you can go back to the initial registration to the final screw delivery. It's all on one screen. A lot of the systems require numerous amount of clicks. The robotic tech is feverishly using the mouse to get through the process. This is a very intuitive, the screen is nice, and everything lines up exactly that you want. And again, something that's approachable from both novice and advanced. Click efficiency, go to any step from one page, a fast, responsive touchscreen. The other problem we've seen with our robotic instruments is they tend to bend. All the frames over time, as they're being used over and over again, they wear. And by wearing, they lose their accuracy. And there are certain instruments, in particular the chicken foot, that tends to potentially be a problem. And so what J&J has come to market with are these disposable reference frames that are lightweight. They're extremely precise, and they're disposable. So they're one use. They really are cost effective when you talk about how they leverage the J&J company with plastics and molding. They're able to get accuracy through reference arrays that are readily used. And at the end of the day, in addition to these four things, the idea is that Velys Spine is here. You'll be seeing it more and more. Hopefully next year we'll have this in demo. The arm, I've been there to Raynham. We at Cedars do not have the robot, so I don't really have a conflict of interest in terms of that. But they really have created the next generation robot. So here we go, sending it to across the country to Raynham at the lab at J&J Medtech. Who is that? Is that Mike?
Mike, hey, can you hear me?
Mike, can you hear me? Yes, we can hear you great. If you can just speak up so we can all hear you well.
Can you hear me? Am I on?
Yes, we can hear you.
They can hear me. Okay. Hey, it's good to see you. You look good on camera.
So do you, Mike.
I appreciate it. Well, thanks, Dr. Kim. Yeah, great introduction. I mean, you really stole a lot of the thunder we were going to go through here, but we are going to spend a little bit of time talking about the hardware. We could keep it super high level, just give a bit of a live demonstration about how all this works. One of the things that I thought was really cool throughout the day is all the advancement in robotics. It's awesome to see Medtronic and Globus and now Stryker with all their robots, such fantastic companies, such fantastic opportunity to innovate and really see what everybody else is doing. One of the things I think is a little bit different about us is, at J&J, we have to be everything to everyone all the time, right? And so a lot of the cool advancements we're seeing are really for those early innovators, those early adopter types, the bone cutting, the osteotomies, the AR, VR. But as Dr. Kim had mentioned, we have to kind of focus on bringing technology to that fatter part of the bell curve, to the everyday surgeon. So how do we create technology, robotics in this instance, that could be used in New York City, shipped to Uganda, and then used the next day as well, right? And so our whole thesis around designing the Velys spine platform was to make it easy, adaptable, and shouldn't really have to choose between robotics and navigation when executing on a surgical plan, okay? So a lot of what's been built into the hardware is to make robotics, again, a little bit more forgiving, a little bit more in line with how navigation works, and again, an easy procedure for the everyday surgeon to adopt, and really not as focused on those cutting edge surgeons, but again, the everyday surgeon that just wants to do a couple cases and get out to their kid's soccer practice, right? So we've already done our surgical plan. Again, not going to spend too much time on the planning. It's very basic. We focus on screws, rods, skin incisions, okay? And again, that's already been done here, right? But when we move forward into the surgical plan or the surgical execution component, right? I have a foot pedal. I'm going to send our robot to the first trajectory, right? Now, again, I think at first glance, you're going to notice a couple different things. First off, the robot, it looks like a robot, so that's a good start for us. I think secondarily, though, one thing for me, it takes a little bit of time to get to that first location, okay? Now, one of the things we hear from surgeons all the time is this idea that they feel a little bit constrained around robotics as they exist today. If you'll notice, in this particular position, I don't ergonomically have great access, right? I have to work around the technology. It's not super forgiving in terms of my ability to operate and have great access in this particular setting, okay? But what makes an active robot very different, as Dr. Kim had mentioned, is this idea of manual manipulation, right? So what I can also do is I can completely adjust the ergonomics of this robot, right? I can get the elbow completely out of my way, okay? And now I have full access. I can recenter that initial trajectory, right? And now I don't run into any problems, okay? So now for a lumbar procedure, that's probably not going to change your life too much. But when you think about the lateral applications, the upper cervical, the pediatric applications, right? Those angles and the ability for this arm to really move in any which position is fairly favorable and allows a lot of great opportunity to apply these types of technologies to those new procedures that really aren't seen in robotics today, okay? Now, one thing that we also want to talk about that's fairly important is this idea of a problem of stereotaxy with patient movement, okay? As my robot gets into position here, right, one of the things that we notice today with robotics is although they're all fantastic, okay, we are still in the stage of just static, rigid drill guides, right? So when I have a static arm and I want to retract a little bit, right, or the patient moves or something changes, right, or I'm in a flexible spine, that robot is going to stay in a static state, okay? With an active arm or active robotics, again, we have a bit of a different flavor, okay? So as I do a retraction, right, you'll notice the arm's going to move right along with the patient, right? If the patient's breathing, you're going to notice the arm move right along with the spine. Now, I don't have to go in and change my trajectory, read register. I really have a good opportunity, and you can see on camera here, that robot arm moving right along as everything is adjusting, okay? So this is all happening in real time. Now, this is important because if I'm doing a traditional navigated case, I have an opportunity to really dock my tool down. I can probably retract or make those adjustments in real time. A robot, I don't get that flexibility. But the forgiveness of this active technology, again, I can dock my tools, I can retract. This is going to be able to move right along with me, right, in real time. So again, from a cognitive load perspective, I don't have to constantly be checking, have things changed, have things moved. It's just that little advancement that really makes this advantageous, particularly for those tougher procedures, right? One of the other things that we talked about, this is the idea of trajectory assistance. Again, a little bit tougher to do if you're not going in traditional bone, but as I place my instrument, right, and again, I'm starting to make these fine adjustments and push on the spine, the robot's not going to allow me to come off track, okay? So again, if I'm really putting a lot of force on the spine or having major issues, the technology isn't going to allow me to come off my planned Z-plane, and I'm able to really execute without any issue. And then finally, right, I'm going to take a screw off and do a little bit of a phantom demo here. You want to focus on the main screen. We talked about that idea of trajectory or screw release mode, okay? So, there's a phenomena that robots have really introduced where when you start to place that final screw and that final tightening, the anatomy is going to shift just a little bit probably towards you, okay? And it's just because of the torque that's being applied to the bone. What that does is it creates a force between the screw head and the driver, which then creates a force multiplier up into the robot, which creates a bit of a cold welding. So if you've used a robot and you've had to kind of add that into your workflow, if I got to take the end effector off and work around it, you're not the only one. We learned this in our verification validation labs that this is a problem, and it was actually something we were able to solve through an algorithm. So our software, and you'll see, when a screw gets about 80% of the way down the pedicle, the arm's smart enough to sort of let out a sigh of relief. It'll actually adjust, and it'll no longer be fighting me or auto-correcting me, and it's going to allow an easy transition to release the screw. So just a quick little demonstration here of how that works, right? And you'll see it come on screen. Screw release mode kicks in. You notice the arm will sort of move a little bit and release itself, right? I'm able to easily release my screw. So some of the basics of active robotics. Really, really excited about this technology, excited about our early partners. We'd hope that every robot in the future categorically is an active robot. We really think that this makes this type of procedure easier for the masses to adopt because of its forgiveness. That being said, that's the end of our quick little demonstration here. Dr. Kim, appreciate you participating with us here, and we'll open it up to any questions.
And Ken Metcalf, you're here as well. Did you have anything you wanted to say, or?
Hey, you stole my thunder. I'm good. My great job, and I also wanted to echo what Mike said earlier. It's been fascinating sitting here and listening to all the other companies and the technologies out there. What an exciting time to be in spine. So thanks to everybody.
Yep, can't wait to, as I said, can't wait to see this deployed more and more. I think you guys have the right stuff. You're thinking about the right things, which is surgeon-directed problems instead of engineer-contrived issues that they hypothetically come up with. And if any of the participants virtually or in present are interested, please reach out to Ken so that you can see it. And J&J, come back next year and showcase your robot to us.
We'd absolutely love to. I appreciate you guys inviting us.
Thank you. Danielle?
That's it.
Where are we now? You're going to close it?
That's it. We're going to close it up. Well, it's 5 to 3. We've kept everyone here long enough. I just want to appreciate everyone who showed up, all the companies, all the faculty, Dr. Johnson, Dr. Kim, Dr. Ross. Safe travels, everybody. And
Mexico City physician.
A Mexico City physician, yes.
Primary care from Pennsylvania.
And this was the 9th annual, so just appreciate you've taken your Saturday to learn some new technology with us.
Okay, and Dr. Kim, come on over here so everybody around the world can recognize us. But stay tuned for next year. Okay, this is 9 years running, and I think we're going to have a 10th anniversary that we're going to try and top all the previous 9. So
all right,
it's going to be exciting.
Thanks, everybody.
Thank you, everybody.